So very quickly, I will do that very quickly. This is on irreducible radial neck fractures. Again, radial neck fractures are common in children, and it's not necessary that you have to get accurate reduction, because again we grow from the elbow and radial neck also grows. So young children up to 45 degrees of angulation can be accepted and it will remodel. And more than 10 years, 15 degrees of angulation can be accepted. So if you are doing a reduction for a 90-degree slip and you come to 45 in a young child, you have to accept it. You should not open. And if you are doing reduction in an older child and from 30 you come to 15 degree, then you have to accept it. And sort of this is a radial neck fracture which is translated. There is no angulation. There is no need to even reduce this, because if you just wait and watch over a period of time, this will completely remodel if there is no angulation. There is no need to take this child to OT under general anesthesia. But if you have this 9-year-old and this is 45-degree angulation, this is not acceptable. And it's very important again to take the right X-ray, because on APE the angulation may be 30, on lateral it may be 30, but if the fracture is posterolaterally angulated, in that plane it will be 45. So you have to see this patient under C-arm before surgery and decide what is the plane of angulation, because it will be completely different. So there are simple methods to reduce. You can reduce either in extension, give varus force, and then push the radial head in. And again you will pronate, because when you pronate, the radial head becomes most prominent. So this is important. These are the tips while reducing in extension. So this is Israeli method, where they want to flex the elbow joint, because that sort of relaxes the ligaments. Then you don't have to give varus force and you can reduce it. And very interesting method is to just apply Eschmark bandage. And this pressure of Eschmark bandage will reduce the radial head. So this works. This works in almost 60% cases. So this patient, for example, I'm using the Israeli method. So I'm doing pronation and then pushing the radial head with direct pressure. And from here to 45 degrees, we came to almost anatomical reduction. And once you reduce, you don't have to pin, we don't have to fix, because it gets stabilized on its own. So you just put the child in slab for 2 to 3 weeks and then start mobilization. The physeal injuries and the metaphyseal injuries in children will heal within 2 to 3 weeks. So you don't have to give plaster for 6 weeks. If you give plaster for a long time, you will get stiffness. Okay? So if you don't get acceptable reduction, the problem is if you don't get acceptable reduction, you can't leave it alone, because if you have malunion like adults, it will restrict rotations. But if you open the radial head, it leads to AVN and stiffness. So open reduction of radial head in children is not very much favored. So if you are left with a situation where the closed reduction doesn't come, then what do? One of the options is to do manipulative reduction. And when you do manipulative reduction, your pressure should not be here like an intrafocal reduction. It should be on the radial head. And this is done with a K-wire. And we don't use a sharp K-wire, use a blunt part of the K-wire. One should take care about the posterior interosseous nerve. So don't go from behind. You go from you don't go from the lateral side, but you actually go from the posterior side where the displacement is present. So what you do is actually pronate the arm so that the radial head becomes most prominent, and then use this wire to fix this. So I'll show you a small video of how this is actually done. So this is the displaced radial head, and this is almost 40-45 degrees, and you need to reduce it. So we are trying to do a closed reduction, and you should not use so much of C-arm, but this was just to illustrate. This is not just budging, and this is possibly because it is impacted. So you make a small opening and pass blunt end of the K-wire, and this is with direct pressure over the radial head. You reduce this, and as you reduce, you should do pronosupination so that it sits in place, and then you check. Most of the time it will be stable after reduction. because there is a metaphyseal hinge. So you just give a slab and that will do the job. So this is after 2 weeks you remove the slab and mobilize. This is from Sandeep, so he has a different way of doing it. So he does intrafocal reduction, like the way I showed in the morning for distal and radius. So he puts a sharp wire through the fracture, topples it over and then advances it, so that wire itself will stabilize, and then he had good result in this case with that method. Many times you can use intramedullary wires to stabilize, because it's not good to have wires which are loose going into the radial head, because they can migrate or they can break. So you can, after reduction, you can stabilize with these wires, and you can turn this wire around to get a reduction, once the wire is passed. So one such patient here, so what we had done was we used the wire to get this into some kind of contact, and once that contact came, I used a simple K wire which was bent to turn around, you rotate it and get it in the right position. So this was what was done. Now these are difficult cases. So this patient had dislocation of elbow with complete fracture, completely displaced fracture of the radial head. And someone reduced the elbow joint, but did not do anything to the radial neck. And the patient came, and he was anesthetist, one of the very senior anesthetist's son. And we tried close reduction. It was not going to come. So finally we had to use this method, what I call as a chopstick method. Because with one wire this was not budging. So what I did is pass 2 wires into the radial head and use this as a chopstick to manipulate this and push it into the right position. And once it was pushed into the right position, then we use this K wire to advance and fix that. And you really have to hammer this wire into the head to fix it well. And still this was not rotationally stable. So we use this wire going from the radial head into the shaft to fix. And this patient, because he had elbow dislocation, there is some myositis ossificans, HO, but eventually, he's got acceptable range of movement and pronosupination. Not full, but quite good for the type of injury he has. Okay, so this is a case which is, a very, very special case, unusual trauma. So what you see here is radial head is dislocated, but it is on the other side of the capitulum. It's opened like a book. Now this happens when the radial head gets dislocated, and when it's being reduced, the radial head remains outside and shaft comes back into its original position. So this is known as Jeffries type 2 radial neck fracture, and this is very difficult to reduce, because in any attempt to reduce this, what comes in between is capitulum. And it is said that you should not even try to a close reduction, but because if you try a close reduction in this sort of a attachment between the radial head and the neck will go, and you will have a completely loose piece, or you may be able to flip it other way around, which is still more disaster, where articular surface will face the radial shaft and the fracture surface will face the capitulum. Then it's a disaster. So we again tried this chopstick method, did not succeed. So I made a small opening, and as soon as we made an opening, this radial head was seen, and then we distracted the elbow manually, and with capitulum being distracted, we were able to push the radial head back, because now we had a way to do it. So you can see after reduction, this is the radial head, this is capitulum, and then because it was unstable, again we passed intramedullary nail from below, and then this did well. This is after 3 months, completely healed, wire removed, and this patient had good range of movement. Now this is a radial head fracture, and this is unusual. I have seen only 5 cases till now, but this needs to be very seriously taken. Even if you have an undisplaced radial head fracture in a child, it needs to be fixed, because the displacement cannot be seen on the X-ray. If it is left and you don't do anything about it, there will be late subluxation of the radial head and arthritis. So that's the outcome. So in this case, we did an MRI, and you see on MRI that this part, the fragment is in contact with capitulum, but the rest of the head with the shaft is subluxated. And it's very important to treat these by fixing the head and repairing the annular ligament, because most of these cases will have some injury to the annular ligament. So in summary, irreducible fracture neck radius which you cannot reduce, the chances are more with older children and displacement greater than 60 degrees. So if you have a child more than 10 years and if the initial displacement is more than 60 degrees, then there are chances that you may not be able to reduce it. You should always try closed methods followed by manipulative reduction, and if that doesn't succeed, there is a place to do a very, very gentle open reduction. Take help of the cartilage hinge, the periosteal hinge, don't damage that, and try to very gently push the radial head back into its position, and the fixation can be done with intramedullary devices. Thank you.